Please come in and take a seat before we are pretty much ready to get started for this session. I'm very, very excited to chair this session with Chris, long-term researcher at Ulster that recently moved to High Point in North Carolina. Chris is one of the people that have really questioned the rise, questioning some of their letters, adding others, and using ankle injuries as a model. He's one of the few people that have actually moved this field quite a bit during the last 10 or 15 years. So it's great pleasure that he took the flights all the way to cold Denmark to give a talk for us, where he'll get into the what should we do in clinical practice, but also the why, the basic science underpinning some of these treatments that we advocate. The floor is yours, Chris. Welcome.
Thank you very much. This is my first time in Copenhagen, first time in Denmark. And it's a great pleasure to be here and talk about this. And I've been looking at this, as Michael said, for a while. And I think it's about time that we really did sit down and question the evidence base for some of these time-honored treatments. I read my kids a lot of Hans Christian Andersen stories, and we're kind of in H.C. Andersen country. So if Michael doesn't mind, I kind of massaged the title a little bit to say, look, we're using these treatments. Is there evidence, or is this just another grand case of the emperor's new clothes? And I guess in order to make dichotomous decisions of whether or not a treatment is suitable or not, we need some sort of criteria in which to base our decisions. So whenever we started looking at this in more detail a number of years ago, when we were developing consensus guidelines for Physios in Sport UK, we sat down and thought, what are the two things that we want our physiotherapy treatments to have? One was to have some sort of underpinning science behind them, so we knew why we were applying it and what physiological effect we were trying to have. And also, that's not just good enough to have that. That also needs to translate through to evidence of clinical effects. So we have to be honest, and we have to call things out when we need to. So let's look at ice first of all. This is the ice man, Wim Hof. Okay, so he loves ice. All right, he spends as much time in ice as he possibly can. He's known all around the world for his cryotherapy-related feats. One of which is he can stay in that chamber for about 90 minutes, which is pretty impressive. So he loves ice, and physios used to love ice. But the tide has changed a little bit. And some people's opinions have got a little bit frosty on it. And it's not unusual now to see headlines like that, that putting ice in injuries could slow healing. So some people are, kind of sitting on the fence. Some people have taken, mood swings that Hamlet would be proud of, and have basically said that ice is completely illusionary. Not only that it doesn't work, but actually it is damaging. And they've gone so far to say that it's worse than bloodletting. Okay, icing is worse than bloodletting. And bloodletting killed more people than the illnesses that it was trying to manage. And it's even killed US presidents. So George Washington was killed not by a respiratory illness, but by bloodletting. And a few people have tried, but icing has never actually killed, to my knowledge anyway, it's never actually killed a US president. But maybe there is something in this idea that ice isn't all it's cracked up to be. So look, it's important to look at the evidence, and I've created a bit of a timeline. So we've been using ice for over 2,000 years, and a lot has happened in that time. Denmark won the Euros against all odds in 1992. But we haven't been as productive in terms of our research output when we're looking at ice, because it took until 1976 to get the first controlled study looking at its effectiveness in humans. 1988, we got the first RCT. We undertook a systematic review in 2004, and then 14 years later, the present day, how many studies, randomized controlled studies, do we have looking at the effectiveness of ice on injured humans? Well, we've got a grand total of 9, which is a pretty poor return for 2,000 years. So we've got evidence from 550 injured humans. So maybe there is something in this tidal change. The other thing that we need to consider is that the evidence in these studies focuses primarily on ankle sprain models. Okay, we've got one study looking at the effect of ice on acutely injured muscle, which is a pilot study, and another one looking at general soft tissue injury. And that's just 9 studies, and I'm not even getting into some of the methodological limitations. So what have we been doing 2,000 years? Well, we've been a bit like the emperor. We've been spending all our money on trying to look good, and we have got lots and lots of different ways to try and cool skin temperature. Meanwhile, the other researchers, our friends across the road who are looking at the effects of ice cream headache, are laughing at us because they've got their studies published in the British Medical Journal. So we're not doing too well. So with this limited evidence base, what do we actually know about ice? Well, look, this is what we know. We know that ice decreases skin temperature, so it decreases pain. So it's a good analgesic. This is what we found within our consensus guidelines for physios in sport. And there have been numerous reviews that have found that it has a quick, fast, effective analgesic effect post-surgery without too many side effects. As long as you follow guidelines, that's fine. So it reduces analgesia. Does it do anything else? Well, based on animal models, and I can find 14, and animal models have found that ice will attenuate or delay certain aspects of inflammation. And again, the green basically shows studies that have found elements of inflammation being attenuated or downgraded or delayed. So it's pretty clear that it impacts on it. Most of them have looked at the effect of ice on white blood cells. So white blood cell activation and migration to an injury site is one of the first things that happens within acute inflammation, and it's pretty important. But what these studies are showing, based on histological examination or real-time microscopy, is that gets attenuated. That response, that element of the inflammatory response gets attenuated. And there's also some evidence to say that correlates of secondary cell injury are also attenuated. So that's based on reduction in metabolism, reduction in apoptosis, and also a reduction in the production of free radicals. So to me, that looks kind of like a dichotomy. Some of these effects might be good, some of the effects might be bad. And whether this is good or bad from a clinical perspective really depends on what way we look at this. So we need to think about it. And as most of the studies have looked at the effect of ice on white blood cells, then we should use these as a model, because what white blood cells do is that they have got some really nasty effects. They're kind of like the wrecking balls of acute inflammation. They produce reactive oxygen species, they spill out toxic enzymes, they create collateral damage. Okay, so if we stop that, that might be a good thing. But on the other side, there is also a positive effect that neutrophils and macrophages have. They phagocytose. They are very important mediators of cytokines and growth factors. So they will impact on maximizing proliferation and regeneration. So we don't really know what we're doing here. And ice isn't selective enough to upgrade the good parts and downgrade the bad parts. It's a one-trick pony. It just gets things cold. So should we be concerned? Well, looking at the animal models, we maybe should be a little bit concerned, because in red, it shows the number of animal studies that have found that satellite cell proliferation, growth factor expression, and muscle cross-sectional area are affected by cooling after an acute injury. Now, these are muscle injuries, and they are animal models, and a rat's gastroc is different than a human gastroc. And the other thing we need to consider to put this in context is that these studies were associated with extreme bouts of cooling. The nice thing about animal studies is that you can cool literally immediately after the injury, and that doesn't happen in human models. There's a delay, and we've got to get people to sign consent forms and that kind of thing. So how directly can we extrapolate this evidence? Well, it's important to look at the magnitude of the tissue temperature reductions in animal models and compare them to human models. So if we look at the graph, at the bottom, this shows application time, and on the y-axis, it shows intramuscular temperature, so superficial intramuscular temperature. And the animal models hit this red zone literally within 10 or 20 minutes, so they reduce intramuscular temperatures to 15 degrees, literally straight after the injury. Okay, so they're right on it. The dashes and the dots show the temperature reductions associated with human models. So you can see that even if we continue cooling for 40 minutes, 50 minutes, 60 minutes, we don't get close to this. Right, so I'm not saying that the effects of ice on satellite cell proliferation and remodeling on animal models aren't cause for concern, but we need to put them into context. We can't recreate the sorts of temperatures that they're doing. Now, what people might say is, okay, well, hang on, what about these new age treatments? Well, actually, we don't need to worry about them. They're neither better or worse than what Hippocrates used 2,000 years ago, because even though they have got and create a very big thermal gradient. Thermal gradient is important. That's the difference between the temperature of the cooling modality and the skin that we're applying it on. They win that, but actually because ice and snow are solid, then they've got a higher thermal conductivity. So it kind of balances out. And again, the evidence now shows that you can go into a whole body cryotherapy chamber at minus 180. Your skin and your deep tissue temperature will cool pretty much the same as if you jump in an ice bath or if you put on an ice pack. So we don't need to worry about those. So based on what we've done to date, should ice be in or out? Well, I think, and people might disagree, even though after everything I've said, I think ice should still be in. You can't recreate the speed and the effectiveness of its analgesic effect. And as we'll see later, movement and loading are very important. So it acts as a very important mediator of everything else. It's cheap and effective, and it means that people might take less drugs, which is good. I think we need to be aware that there is some evidence from animal models of an attenuation, but the clinical relevance in humans is not clear yet. And if you're concerned, I think it's absolutely fine just to stick to shorter, intermittent applications for pain relief. Okay, what about compression? Well, you can see a trend here, okay? So we spent a lot of time trying to look good, but not a lot of substance to it. The evidence base for compression in injured humans is as sparse as it is in ice. So this is all the studies that I can find that use compression on acutely injured soft tissue injuries in humans. Again, the majority are ankle sprain. We've got one looking at the effects on muscle injury. So it's pretty bleak, and we'll come back to these studies a little bit later on. But I think it's also important to think about, why do we apply compression? What are we actually trying to do? And is dose important? So what does compression do? Well, compression has the capacity to do a lot of things to our vascular system. Okay, so one is that at lighter levels of compression, it shunts blood from the superficial to the deep vessels. And that is a bit like clearing traffic by moving it from a country road to a fast lane freeway. It increases the volume and it increases the speed of venous return. If we apply greater compressive pressures, then we narrow the vessel, we increase blood flow speed, and we also increase the volume. Okay, so we shunt it proximally. Okay, that's one rationale. That carries over to clinical evidence, not in acute soft tissue injury, but whenever we look at the effects of compression stockings on DVT risk, we see that there is carryover. There is evidence to show that it decreases pulling, it increases shear, it decreases the risk of DVT in flights, post-surgery. So clearly, compression does something to our venous return to stop congestion. And that's fine. But remember, we're dealing with an acute soft tissue injury where there is compromise to the equilibrium at our capillary bed. Okay, so whether or not fluid moves in or out of our vascular system really depends on the aspects of the Starling equation. And that gets really challenged after an injury. So what tends to happen is that the hydrostatic pressure within the vessel increases, and that has a tendency to force fluid out into the interstitial space. Now, normally what happens is that the colloid osmotic pressure within the vessel then pulls that fluid back in, so there's no real net loss or gain. So it goes out and it comes back in. Hydrostatic pressure increases post-injury, so we get more fluid out, and we also lose that osmotic return because all of the white blood cells and all the other big cells have moved to the injury site. So we get a net change, and we call that edema. Okay, and edema is a problem because edema separates our capillary bed from our cells. So it gets starved. In other words, we take our cells further away from their food source, and that can contribute to secondary cell injury and secondary cell death. So one of the rationales that people will use for compression is they're saying, okay, well, all we want to do is just shove that edema out of the way so that our dog can get to its food. In other words, so that our blood can get to our cells and we reduce the secondary cell injury. So it's a bit like a kind of robbing Peter to pay Paul idea. We don't care where the edema goes, just as long as it goes away from the injury site. And we get these nice little crop circles that appear here. And that's the idea behind focal compression. And that's fine, and that makes some sense in my head. The other reason why people would propose that compression works post-injury is that if we've got this increase in hydrostatic pressure, then if we can apply an external compressive force, that will help to increase interstitial pressure and kind of counteract it. So we can kind of push against that hydrostatic pressure and stop it. And that, again, makes sense. But the other thing that we need to consider is that lymphatic flow is also very important, and that's kind of the other end of the Starling equation. And does compression make sense for lymphatic drainage? Well, we need to consider something about lymphatic function, because this is what a lymphatic vessel looks like whenever it is functioning well, whenever it is draining edema, whenever it was dealing with excess interstitial fluid. Okay, so it relies a lot on having an intact extracellular matrix, so that creates a level of rigidity around it, and it creates tension on these little things here. Okay, the suspensory ligaments, and what that does is it pulls the lumen out, it makes the lumen bigger, and that creates a negative pressure, and it kind of acts like a suction, so the fluid comes in and everything works really well. But the catch is that it needs an intact extracellular matrix in order to do that, to keep tension on these. But injury creates damage to our extracellular matrix, and it's a bit like cutting a puppet string, so the tension around the lymphatic vessels gets cut, and they kind of collapse and look like that. So does it make sense putting more circumferential external compression on that? Well, it's a bit like saying that if we wanted to get our tent to look like this, we would put more external pressure on it, when actually what it needs is more tension on the guy lines. So that, to me, doesn't make sense. The first couple of reasons for applying compression to me make sense. In this, I have a harder time. Now, I'll caveat, I'm not saying that kinesio tape can do that either, because we need this coming in 3 dimensions, and it doesn't do that, so I'm not going down that line, don't worry. But compression only makes sense for part of Starling. So I would question how good it is at dealing with edema. And it's not just me, because if you look at the clinical research, none of the studies that have looked at the effect of compression on an acute soft tissue injury in their introduction or in their background have said anything about the millimeters of mercury. They've said nothing about what their compression bandage is actually going to achieve at a physiological level. All they've said is, my device is going to be better than what's currently done. Now, I don't know whether they've got shares in the devices or not, but what I do know is if you compare compression with compression, then you're going to find that compression is effective. And this is a problem, because there's so many different compression bandages out there, and they don't all give us the same dose. So some of them will give a single dose, like a tubular bandage of about 15 millimeters of mercury, and others we can vary it. So this goes from the very cheap, not fancy, to the very expensive and fancy, where we can change the external compressive pressures from 0 right up to above 80 millimeters of mercury. So what's best? And do some of these do some of the physiological effects and not all? Or are we able to select which physiological effect that we're achieving based on changing this? Well, these studies didn't set out to find that, so it's quite difficult. But do they tell us anything? Well, if we look at the comparisons that have been made to date, okay, so this is just like a matrix. So we've got no compression, tubular bandage, stockings, elastic, rigid stirrups, and intermittent pneumatic compression. So we can see from this that very few studies have compared compression to no compression. So we don't really know if compression's any better than not compressing. All right, what we do know is that pretty much anything is better than a tubular bandage. Okay, and that has been done through some research looking at the effect of tubular bandages on ankle sprains, and the reason is that it creates a tourniquet effect. Okay, so this is Tufts' work back in 1994, and they found that the highest compressive pressures are above and below the injury site, and the lowest are the pressures at the injury site. So it kind of creates pressure peaks here and here, and a tourniquet effect. And I was external on a PhD last year, and this work hasn't been published yet, so I don't want to say which compression bandage it was, but it's a very popular one that's used around the knee. And in their research, they found exactly the same thing, that the compression bandages were creating a tourniquet effect. So pressure peaks, they weren't graduated, and that doesn't make any physiological sense. The other thing that we have found is that intermittent pneumatic compression and rigid stirrups are probably better than elastic bandages. So there's a little bit of a trend to say that higher compressive pressures or intermittent compressive pressures are better than lower single compressive pressures, particularly if the compressive bandage doesn't conform to the body part that you're trying to treat. So we can't really get a lot out of that. And as I said, most of them have compared compression with compression. And, you know, I'm kind of reading into this. This isn't what the studies were designed to do. They really didn't have an underpinning physiological rationale. So what do we do about compression? Well, this is what I think about compression. This is a very famous Danish physicist, and he came up with the idea, the principle of complementarity. So basically what he was saying was that small objects can exist as both a wave and a particle at the same time. And I think compression is similar to this, because compression can apply external compression, but the other thing that it does is it creates a little bit of a virtual crutch for the patient. Okay, so if you give somebody a compression bandage, they feel a bit more at ease, they feel a bit more comfortable, they feel a bit less scared. And I don't know whether I'm translating this correctly, but or pronouncing this correctly, but it reminded me of this idea of hygge. So is this how compression works? Well, I would suggest that might be a way. So before we throw it out, I would suggest that, okay, there is a bit of a link between some compression bandages and this, but because they haven't considered the physiological rationale, or because they haven't considered how much loading people are doing when the compression bandages are on, maybe, and this is just a hypothesis, maybe it's acting through another way. Maybe it creates this level of comfort, people mechanically load more, and we obviously get some direct effects of mechanical loading through mechanotransduction, etc., and we'll talk about that in a second, but they also move more, okay? And all these things they're trying to do is recreate what our body does really well through movement and through muscle pumping. So if you really want to decongest and if you really want to drive blood around your system, then just move more. So that's my hypothesis, again, is compression in? Well, it was out before I came up with that hypothesis, so I think it's in by a nose, but I would suggest that its most powerful effect is probably mediation through movement. If you are thinking of applying or choosing a compression bandage, don't do it on price or the color, just get something that is comfortable, that is graduated and conforms to the body part. That's it. All right, what about elevation? Elevation is my favorite because it makes most physical sense, and there's a real rationale for elevating. Instead of trying to force the fluid back in because the hydrostatic pressure is too high, then just negate the effects of gravity. Put your foot up and the hydrostatic pressure will decrease. Unfortunately, we've only got confirmation from one clinical study to show that elevation works, and unless you can walk about like this and keep gravity eliminated, then it's not really going to work, because you get a rebound phenomenon when, as soon as it goes down to a gravity-dependent position, everything fills up again. So again, maybe it provides a window for rehabilitation, because if you've ever had a hand injury or hand surgery or ankle surgery, you will know that it's pretty sore. Elevation will help. Maybe it provides a window for more movement. I don't know. The risks with it are that it just becomes too passive, and it becomes kind of like a pat in the back for the patient to go and put their foot up or put their hand up and get a cup of tea. What about rest? Is rest in or out? Well, rest, we all need a rest, and we saw in the talk earlier that after we load, we do need recovery time, and for certain tissues, there is a kind of a ceiling effect on the amount that we can load. So there needs to be a balance. But rest in isolation will not work. The second law of thermodynamics suggests that things go from order to disorder, and in order to change that, we need to exert some sort of energy on our system. So if you just leave your desk alone, it doesn't clear itself. It doesn't clear with rest. And there is lots of evidence now from animal models to show that if you injure a muscle or a ligament or a tendon and you just let it rest, then that increases the disorder or randomness in the system. So the extracellular matrix is more disorganized in stress-shielded tissue after injury, and that has a knock-on effect on its viscoelastic properties. So it's less stiff, it's got less tensile strength, and it's more likely to rupture. So rest doesn't make any sense. And, we are responsible for choosing which type of energy we put into the system. And we've got a gamut of different types of energy that we can put on healing tissue. We can, put light energy in it. We can shine a red light on it, or we can make it vibrate with ultrasound, or we can move it and mechanically load it. And that works the best because that is what our systems are used to dealing with. That is how they developed, and that is how they maintain homeostasis. So in animal models, what works for animals is, it's a bit of an oxymoron, but free cage activity. Okay, so if you injure an animal and then let it run about the cage, then it is putting energy into the system, it's mechanically loading it, and it helps the tissue change from this back to this. It becomes more organized, it becomes stronger. I call this optional loading, okay? So the rats have the choice as to whether or not they want to load or not. And we do free cage activity with humans. We just call it functional rehabilitation. Okay, so we put a bandage or something on them, wave at them as they go out the door and say, okay, you can walk if you want, it's really up to you. The walking will make you better, but it's completely up to you. And we were interested in whether or not people actually chose to load after they were discharged after an ankle sprain. And what we found were that actually they did. They loaded. So post-ankle sprain, we put some activity monitors on people and then brought them back a week later. We told them to move as much as they could within the limits of pain. And they did it. And on average, most of them accumulated about an hour's activity, which is more than some healthy adults. So we know that if we give humans free cage activity or functional rehab, they will choose to load. And that's good. So we know that some form of loading is better than rest. It's better than no loading. But the question is adding more load on the functional activity, does that increase our clinical outcomes even more? Well, again, we looked at this using an ankle sprain model, and we subgrouped the interventions into three.
Yeah, thank you for that great overview, Ben.
They were based on increasing load. So the lowest load
we just finished studying xenon, which
basically
became
no
popularized
load.
after
They were
an article
mobilized.
in The
Okay.
Economist,
Intermediate
prior to the
loading was
Sochi
based
Olympics.
on
And
just
you put it on your
functional,
slide, and I just want to warn everybody that it is a
not
very
functional
potent
rehabilitation, but just a
anesthetic,
free cage
and it
activity. Okay, so
causes
just given a bandage
anesthesia, even
and
at
told to walk.
doses
And
that are
then
used by
the highest
athletes.
level
And
of
we just
load
finished
are
a
basically studies that have
1-month
used the
repetitive
functional approach to
xenon
managing an
dosing,
ankle sprain,
and it doesn't
plus
do
they have
anything.
added on additional
So it's
rehabilitation.
dangerous and
So
does not enhance
I know it's a little bit
performance. So any
crude,
of you who
but
work
we can
with
kind
athletes,
of, subgroup
it's
those into
been
low load,
banned
intermediate load,
by
and high load.
WADA,
So we were
even
interested in
without any
seeing whether or
evidence,
not
but
these
it
were
really can
associated
hurt
with
people, so be
a
careful with it.
better clinical outcome. And we were able to get data from 11 randomized studies and grouped them together. And we looked at it like this.
My name is Niklas,
So-
I'm a GP from Sweden.
Just to set this graph, this is
it
the
possible to
duration
design
of each respective
EPO,
intervention.
as in the
We were
Balco
most
case with
interested as
steroids
clinicians
to-
as the
To design
the prevalence of re-injury,
EPO.
okay, and
Or
the
is it
green,
takes,
amber, and red depict whether or not
Yeah,
the intervention
and then
was
you can avoid
low
detection,
load,
yeah.
intermediate, or high load. And what you can see from this is that actually all of the poorer outcomes are generally amber or red, and they're up around here with a higher re-injury rate. The higher loads are associated, generally speaking, with lower re-injury rates. So that carried over when we did a more traditional analysis in this and looked at an odds ratio. The higher loading, so whenever you do functional approach to managing an ankle sprain plus rehab, it reduces the odds of injury by about 50%. So more loading is better, and that's just further evidence to show us that. So based on this, rest is definitely out, loading is in. But loading has to have a purpose. And we need to move from this idea of just optional loading or kind of mindless loading to optimal loading. And one of the reasons why we wanted to include optimal loading in an upgraded treatment acronym was to try and change the mindset of patients, to try and change the mindset of therapists. And not saying that we have all the answers as to what optimal loading actually is, but it's a little bit, hopefully a little bit of a paradigm shift in the way that people will think. By definition, optimal loading is basically just having an underpinning rationale for why you're loading and trying to figure out what you're actually trying to achieve with it. So in other words, selecting a loading strategy that will maximize a particular physiological response. And it's a bit like tissue engineering. Okay, so the loading variables that you choose will determine what type of tissue is laid down. So the function will drive the form. And again, there's lots of evidence from animal models to show that post-injury, if you compress the tissue, the ligament tissue when it's healing, it will lay down more type 2 collagen because it'll probably think that it's cartilage or something. If you evoke tensile load on it, it will lay down more type 1 collagen. So we know this, but the point is that tissue is sensitive, very sensitive, to the type of load that you put on it. So we can't just mindlessly pull loading strategies out of the sky. The other example of this is nice. This is kind of like a ball and socket talocrural joint, and the reason why it's developed this ball and socket is to try and develop more range within the frontal plane because the person has got a subtalar coalition. Okay, so again, it's another example of how the function and the load that we put on our tissues will drive its form. So the loading variables are really important, and we tried to summarize these based on this Venn diagram. And I know Venn diagrams aren't, in this day and age, aren't the best way to approach treatment. We need evidence, but unfortunately, there's not a great deal out there, and we'll look at that in just a second. So the nature of the load will dictate the clinical outcome. And it was great to see some excellent evidence, some of Bayer's work, getting in and getting the credit deserves in the New England Journal of Sports Medicine. Because sometimes the nature of loading is just changing the time that it is initiated. And again, there was very clear evidence from this that if you start loading earlier on muscle, then you will get better returns. You will get a faster return to play without any decrease in the risk of re-injury. So optimal loading might be just when it occurs. And we did some, not as good as this, but we did some work that basically showed the same thing post-ankle sprain, that actually you can very safely load early on in the acute stages without any additional risk in re-injury. I think there's also some excellent work from Australia that has highlighted within hamstring injury, it's not just about mindless selection of exercise. And David Opar did a great talk at the Optimal Loading Conference in Belfast, and they produced this study recently, or this review recently. And again, it really underpins what optimal loading is all about. It's about the fact that exercise selection is important. It shouldn't be mindless. Not only does it affect muscle activation, but the type of exercise and the dose that you do will dictate which physiological effect you will upregulate or downregulate. So again, it comes back to, do we have a physiological rationale for what we're trying to do? What is the rationale for loading in the management of acute ankle injury? This is something that we were really interested in, and this study is in press at the minute. But whenever we broke down the rehab programs and tried to figure out what the interventions were all about, primarily they're about addressing impairments, which is fine. That's really important to address impairments. But just because you address impairments, it doesn't necessarily mean that will maximize loading on the healing tissue. Because whenever we looked at the nature of the treatment interventions, the majority of them were undertaken in a neutral foot position, in a closed chain, and they had sagittal plane dominance. So that will address some of the problems, some of the limitations, and some of the impairments, but it's not going to maximize the load on the tissue. So how can we improve that? Well, the first thing we need to do if we're using ankle sprain as a model is we need to move away from a neutral position. Because if we really want to stimulate tissue, if we want to stimulate mechanoreceptors, because ligaments are sense organs and that needs to be changed, then we need to move into really extreme positions. And if you look at something like the CFL there, which is here, that only really becomes loaded in extreme dorsiflexion. So if we're undertaking all of our balance work in a closed chain in a neutral position, then that ligament won't really be stimulated. I guess the other thing, again, using ankle sprain as a model here, is to appreciate how much that ligaments do in the transverse plane. So again, this is the talus. Remember, the talus doesn't have any muscle attachments, so the ligament function is really important. But if you look at the amount of rotation that is happening, the amount of rotation that's happening around the z-axis, that needs to be recreated in the exercises that we choose if we want to load the tissue properly, if we really want to stimulate it. And some of the nice work that Steve DeChavy is doing, with the knee, but it's a similar idea, is trying to shift some of the rehab exercises to include more challenges around the z-axis, because ultimately that is how the talus, for example, is loaded whenever we function. Optimal loading is also about considering the mechanisms of re-injury, and again, using lateral ankle sprain as an example. It's got a really high re-injury rate, even if we undertake rehab. But if we look at the clinical studies, and if they're doing all of their rehab in closed chain, then it's probably no wonder that the re-injury rate is high, because what we know about the injury etiology is that most of the re-injuries occur through sensory motor error within the open chain, because people are already in too much inversion before they even hit the ground. So that should be manifested in the exercises that we choose. And again, some of the stuff that we're looking at the minute is finding better ways to re-educate sensory motor control in an open chain, and also to give people feedback, to give them the opportunity to make mistakes, because that's what motor learning is all about. This person has got a long history of repetitive strains, and you see just how poorly we're telling them to trace some of the lines here. You can see how jerky and how poorly they're actually doing on that. Okay, so keep the re-injury mechanism in mind whenever we're choosing the loading strategies. What else do we need to consider within this diagram? Well, we probably could have compressed these into to one thing, but it's the dose, the frequency, the duration, the intensity, and the magnitude. And again, the speaker this morning was highlighting the importance of that whenever we're looking at tendons. But for most acute soft tissue injuries, we have got very little evidence, very little information on what an optimal dose should be. And part of that is because the studies that have been undertaken are too few, but they also provide very little information on what they actually did. So the reporting is poor. So rehab in clinical trials has become a bit of a black box. We know that they did some type of rehab approach. We know the outcomes, but we know absolutely nothing about what happened in the middle. So we're never going to get to the stage of trying to make some better decisions on what components of dose are important unless we know that level of information. And I guess that is a wider problem, and there has been some really nice debate on that about trying to find the best methodological approach to try and solve some of these more complex problems. And I don't want to get into it too much, but I think if we're dealing with trying to figure out what load works best, then we can't rely purely on pragmatic research. And I don't think that only using randomized controlled trials is the way forward on that. But that's probably for another debate. Okay, this is telling me I've been talking for nearly 50 minutes, and I want to make sure that there's some time for questions. So just to try, I've talked about a lot, and I want to try and compress it into one path model at the end. Okay, so look, we know that the evidence isn't as good as it should be. There is some physiological rationale for some of these interventions, ice compression and elevation. And in some studies, there is a link that they're associated with components of recovery. But that's not what this is all about. There is an element of Emperor's New Clothes in this. And we really need to call it out. But that doesn't mean that we throw the baby out with the bathwater. They still have a role, and I still think that a lot of their effects are simply helping to mediate what is the main thing that we should be focusing our efforts on, is movement and tissue loading, and trying to find the best ways to do that. But just because you load, it doesn't necessarily mean that you will get a better recovery, and I've thrown in a moderation because the effects of tissue loading on recovery are moderated by the loading variables that you choose. Now, we know that loading variables are important. We know that tissue is quite sensitive to loading variables, but we've got to go and get much more evidence on that. Okay, thank you for hopefully paying attention. I'm happy to take any questions.